Good morning. My name is Michelle Riba. I'm a psychiatrist here in the Department of Psychiatry at the University of Michigan, and I welcome you to this panel on fighting stigma through policy change. I am also proud to be the president of the American Psychiatric Association this year, and as you could hear from this morning's discussion, there are a lot of issues for the APA to take on. One of them, though, is the importance of the issue of mental health on college campuses. And I've had the pleasure of being able, as president, to direct a task force on this issue and have asked David Fassler. David, are you in the audience? There. Who's a child psychiatrist and on the board of trustees of the APA, and Rachel Glick. Rachel, great. Former associate dean here at the University of Michigan to co-lead this task force. So wanted to let you know about that, and maybe you'll have an opportunity to talk with them later about that. This is an important topic this morning, and we have a distinguished panel to talk to you about this. I wanted to let you know that Dr. Carol Mowbray is unable to be here today. There was a death in the family, and we send her our condolences. Our first speaker is Maryanne Kirkbride, who's the clinical director for campus life at the Massachusetts Institute of Technology. And Maryanne will talk about community health approaches to reducing stigma on campus. Maryanne?
Good morning, everyone. Thank you very much for that kind introduction. In 2002, MIT Medical created a new position. There was some talk about it in this community and at these sessions a couple of years ago. It was a position to bring together and expand on the department's community mission. It's a senior leadership position, and I've had the privilege of being the incumbent in that role. It's called the Clinical Director for Campus Life. That was a title that was designed by a committee. It is a very broad title, and I've really enjoyed my time there quite a bit. Most of the work that I've done has fallen into one of these buckets. It's been a broad role. It's developed over the course of the period of a couple of years. I'd be more than happy to talk about the role and its impact on campus or any of one of the sub-roles that I've taken on campus, but I really want to focus today on community health aspects of that job and where we're hoping to take that role and expand it moving forward. My main concept today is to take, excuse me, can I have my water? Thank you, I apologize. The main concept today is to bring the kinds of expertise and best practices that our partner communities use, our civic communities use, and see how they apply on college campuses, which are really small, purposeful communities in and of themselves. What I'd like to do is share with you 4 concepts, talk a little bit about how they work on civic communities, how they apply to college health, and then give some examples about how we can use them to take action. The very first concept is a structured approach to community-oriented health systems planning. 3 main concepts, which I might say couldn't be happier to follow on the conversation that just ended in this room before the break, because this is very related to that effort. We work in collaboration with our communities to think about the strengths and weaknesses of our programs. We use data to drive policy, and we help assure the availability of high quality and effective systems. Historically, people think that health systems planning is an executive function, and that's generally true. But in active communities with people who have health advocates throughout their community, it's really a collaborative process where everyone can have a hand in it. And I think, again, in the last conversation, we see part of the normal dialogue about services, service use, opportunities, and strengths to discuss these things and make services better as a result. The second concept is a holistic approach to population-based activities. So in a civic community, my public health and community health brothers and sisters will be concerned about health surveillance, about public education, early disease detection, injury prevention, and environmental health programs. And in this case, I'm not talking about recycling. And how does that work on college campuses? Well, we may have some health surveillance information. We may already know how many people are coming to visit us in our mental health services. We may know for what. We may know about burden of disease. But if you think about a more community-oriented approach, you might also want to know what about indicators that are outside our health system? How have we worked with our community to share what we know and to discuss our findings? In fact, do our community leaders feel like they have a stake in the information and a stake in helping us make improvements? And how does the health surveillance part of what we do inform the rest of these population-based activities? I think we've seen a number of great and visionary examples of all these kinds of activities here in these past 2 days. There's lots of campus programming for education and early disease detection. We have depression screening days and so forth. For injury prevention, there are helplines, crisis intervention programs, and environmental programs, counteracting some of the commodification of our students that Dr. Weitzman talked about yesterday, culture change and marketing initiatives. Those things all exist in various levels in our communities. The opportunity we have is to consider them holistically. How does one feed into the other? How can we look for opportunities based on the needs that we have on campus to strengthen those things? And how does the holistic view uncover opportunities that just that just programmatic observation does not? Third concept is policy development. This is really a code word for developing a strong and active constituency. We really are working hard in our campuses to inform and educate and empower people about health issues. We can use our peer advocates for this purpose. We can have programs about the state of the health of the dorm or the state of the health of the institute, a la State of the Union, to talk about what's working on our campuses supporting health and what things can we improve on. We can work to mobilize community partnerships, considering the advisory group model in many other kinds of civic communities, the HIV community and cancer community, survivors and consumers are very active in providing resources for critiquing programs and ideas for strengthening them. And just as an aside, if any of you presented about the Student Health Advisory Committee work at the, I think it was 2000, American College Health Association conference, I thank you very much because our health educators brought back a lot of information from that conference and we've really been able to make good use of it at MIT. And the policies will, if you have an active constituency, policies can fall out of that can do what policies need to do. And that is, they need to be meaningful to the communities that they're applying to. They need to be broadly understood by the students and the staff and faculty in those communities. And that working in concert with your community, you'll develop policies that have a much better chance of success in that endeavor. And that brings us to the fourth concept. We've talked about how everyone can have a handle in health systems planning. We've talked about how we can consider population-based activities as a whole and then how that flows into policy development. But we could ask the question, for what? Where are we going to target our resources? How are we going to know what health activities are most important on our campus? How do we know how healthy we are? And the answer is to take a look at what determines our health. Health is way more than the absence of disease. It encompasses spiritual, physical, emotional well-being. And it's affected by a complex interaction of many factors that are collectively known as determinants of health. This is actually an active field of research, primarily in the EU and in Canada. And I may say that some of the listservs that I'm on where people are studying this, a number of the researchers in the northern part of the United States left and moved to Canada immediately after our last federal election. The big idea here is to delve into what makes up each of these health determinants and look for doable projects, change areas that we can change and improve that could increase awareness or help our students on campus. The other concept is that these things are interactive, so one of them can take picking them apart and seeing how they contribute to the cause of a student's or a community's distress can help us find solutions that may elude us otherwise. So here's a couple of examples in each of the buckets. In the first bucket, there's international policies, immigration status, which I know a number of our campuses are struggling with, the SEVIS system, for example, cultural values and norms, discrimination or fear of discrimination, and some bread and butter things like transportation and childcare. Living and working conditions, economic resources and conditions and availability of housing, exposure to hazards, including cigarette smoke, and accessibility to community resources, other people, food, programs. Social and community influences include everything that drives social inclusion and social exclusion, as well as community involvement in decision making. And here we are where things we actually operate in our world pretty much every day are individual lifestyle factors. Diet, activity, personal risk and protective behavior, self-esteem, locus of control, those kinds of issues. And lastly, biological factors, age, sex, genetic makeup, which taken as a whole and for populations need to be considered as well. So how does this work? What's an example of how this might work? Well, for example, say you have an incoming freshman student who comes from a very affluent community, is used to having a boatload of personal amenities, her own bathroom, her own cell phone, her own microwave, I don't know. And she comes during a year where there's a high freshman yield, and so she'll be crowded in a dorm where she shares a bathroom. She has very little negotiation skills about that sort of thing, and what ends up happening is that she ends up in the office of the mental health service. Well, just describing that situation, we've taken into account a number of these determinants of health, and when you ask the question, where would you make the fix then? What would you do to help? Well, obviously, you need to have the mental health services at the end, but maybe the real consideration is how do you orient students like that to campus, and that happens long before she ever goes to her first class. Thank you. The good thing and the fun thing about this is that these things are related. So the social determinants have influence over what happens behaviorally, what happens clinically, and what happens group as a whole in terms of health outcomes. The behavioral things impact the clinical situation and also what happens with health outcomes. And there are, this is the place where using this diagram, anybody on campus, parents or off campus, parents, teachers, students, health professionals, administrators can think about these things and think about how the health of the campus, they from their role can affect the health of the campus as a whole. So for example, if you're a healthcare administrator and you observe an uptick in a clinical indicator, say the number of students who are already coming into campus, a number of freshmen are already coming into campus on SSRIs, you can look downstream and see if that's considering that a clinical indicator, we can look downstream and see what happens at the end of the first semester in terms of healthcare utilization. You can look upstream and see if those students, do we need specialized training for residents, life staff, because those students might feel ostracized about having their medication in their dorm room. Do we have issues of just sheer pharmacy and renewal, and how are we going to manage those things? So you can look upstream and downstream and think about the impact of changes that you see. If you're a clinician and all of a sudden you realize that, gee, students from a certain hockey team or dorm are previously who might have come in for care early on are really delaying their care seeking, and that's really a clinical concern that you have, and it's behavioral as well, and you can look downstream to see the impact of students who are coming in sicker, and you can work with campus colleagues and look upstream and see, well, is there some kind of a predictor or indicator that is all of a sudden making this change in our practice pattern? Was there a student who perhaps may have perceived having a bad experience in terms of care in the mental health service, and all of a sudden word is out that people shouldn't come in? Or was there any other kind of concern about people who might be seeking care later for whatever reason? And talking to students is always a good thing about that, but talking to other people in the community as well. So if you're a student, and let's just say, for sake of an example, if you're a student at a technical institute where you know among your campus colleagues that there is a premium, there is a bravado about staying up late, about doing as much as you can with as little sleep as possible, with adding caffeine tablets to your Red Bull, with how long it takes, how many projects you have to do in a short of time you have to do it in. And let's just say you're a member of the Student Health Advisory Committee. You can think about what's going to be the downstream impacts of those social determinants. What could you advise the campus health colleagues, your colleagues on the Student Health Advisory Committee, that they might want to plan for? You can think about what kinds of interventions to make in the social realm. And in general, you can think more broadly and put the interventions in the right place if we're all working together and thinking about what determines the health of the campus. I would like to stop there in the interest of time, and I'd be happy to answer any questions afterwards.
Yeah, I believe you have cards that you can write down your questions and hand them in, and we'll try to take them all at the end. It's my pleasure now to introduce Dr. Richard Kadison, who's the chief of the mental health section at Harvard University. Dr. Kadison is a child and adolescent psychiatrist and has been working in the field of student health for over 25 years. He's also the author of an important book, College of the Overwhelmed, The Campus Mental Health Crisis and What to Do About It. Please join me in welcoming Dr. Kadison, who will be talking about getting students into care, collaboration and creativity from the top down and the bottom up. Dr. Kadison.
Okay. First of all, I want to thank Dr. Graydon, Sarah, and Lynn for, again, pulling together a wonderful conference. It's great to be here, and it's great to have the opportunity to have this interchange. I think one of the most important things we all need to do is have the opportunity to talk to one another, to learn. As I go around the country, every time I go to a different place, I get new creative ideas that are happening on different campuses, and the more of this we can share with each other, the quicker we'll move things along. I think we're all challenged today, the four of us who are presenting, to try to condense our hour-and-a-half lectures into 10 minutes. But we'll do our best with this. And I want to start out by sharing a couple of stories to put this in perspective for myself. First, I'm going to talk about my own experience as a college student. I grew up at a suburban high school in the Midwest and went to a competitive Eastern school. And when I got there, I thought I was fine. And through the 4 years, if you asked me, I probably would have told you that I was fine. But in fact, I was kind of shy, had a social adjustment. It was difficult being around so many other smart people. I definitely drank way too much on the weekends. And if someone had suggested to me when I was in college, why don't you go to the counseling center, my response would have been, what's the counseling center? There was just no concept of campus resources, and wouldn't have occurred to me to access the campus resources. Another story is around a student that I saw spend a day a week at Harvard Business School. And a student who I saw 5 or 6 years ago was severely depressed, was suicidal, was deciding whether to drop out of school, wasn't sure whether she should go into a hospital or not. Came in, started therapy, was on some medication, and pulled herself together fairly quickly, the kinds of stories that you like to hear about. And she wrote a letter to the campus newspaper called Being Depressed at HBS. And they published the letter, and after the letter was published, probably a dozen students came in over the next couple of weeks saying, I had a lot of these symptoms. Never occurred to me to come and talk with someone, but reading this story really helped me to put this in perspective, and it led to a lot of people coming in and seeking help. And the newspapers run the article once or twice a year, every year since that time. And every year, at least a half a dozen to a dozen students are touched by the article, and it helps them to recognize their issues, and they come in and seek care. And I think as professionals, one of the things that we're all most frustrated by is the amount of suffering that students go through before they seek care. So I'm going to talk more about the structure of that and what we can do about it. The third story is the National Depression Screening. Every year we do the National Depression Screening, generally when our mental health service tries to advertise and encourage students to come. We get 10 or 12 students to show up for the depression screening. 2 years ago, there's a mental health advocacy group on campus of students, and we said, would you help us advertise and kind of get the word out about the screening? And with their help, we had 150 students come in. This year, the director of our Center for Wellness had the brilliant idea of giving away an iPod. Harvard's endowment has done well, but there was no better investment than this iPod. We had we ran out of forms. We had 780 students who came in to take the depression screening. Now, I know that there weren't 780 students concerned about whether or not they were depressed. There were, 750 students who wanted to win an iPod. But it gave us a chance to interact with the students, to spend 5 minutes with these students talking about the warning signs of depression, going over their test scores, and it was an opportunity to plant seeds and interact with students. So I think it's a crucial, these kinds of events and kinds of opportunities are out there, and we really have to take advantage of them. So what is the core mission to help reduce stigma? First and foremost is the commitment from the college or university to attend to the emotional well-being of students. And this is really a win-win situation. And one of the things when I talk to deans and administrators around the country, if a student can't get into care, can't access services, stumbles academically, and there's a clear connection between emotional and physical well-being and academic success, I'll talk about that a little bit, then the student may end up leaving school. And if a student leaves school, that's $60, $80, $100, and $120,000 lost to the institution. That pays for a fair amount of health care. Some of the comments that Paul was making this morning, these are good investments. These are no-brainer investments when you put it in the bigger context. How do you reach students? I think this is one of the things, again, reducing stigma. One is that I think you try to focus things around wellness and health activities and get away from the pathology focus that we tend to have. One of the things that helps students maintain their mental health is if they eat, sleep, and exercise. And if I had much more time, I'd talk about the importance of sleep. And Roseanne Armitage from the University of Michigan last year gave a wonderful talk about how students are sleep deprived, how that affects their academic performance, and puts them at higher risk for depression and other kinds of problems. Meeting students where they live, getting out of our offices so that students can see that we're real people, that we're out there having talks with students, hearing from students what their concerns and issues are, what they're thinking about, is a crucial way to help reduce the stigma. And also getting out into the community. Our mental health advocacy group has met with some faculty groups. There's a teaching orientation for new incoming faculty around teaching. The students talk about how you approach, if a student approaches you who's depressed, These are things that you can do that have made a big impact on faculty. Now, the biggest problem that we see on campus is stress. It's the #1 problem on campus. I'm going to go through the details. We've discovered a fantastic new technique to determine whether you're too stressed out. And I'm going to have you all take this test right now. I'm going to show you a picture of 2 identical dolphins. If you see more than 2 differences between the dolphins, you're too stressed out and you probably need a vacation. They look exactly the same to me. From the American College Health Association data, what students report the major impediments to academic success, and I think this is part of the message we need to get across to administration. Stress is #1. Cold and flu and common medical problems are #2. Sleep difficulties are #3. Depression is #4. And, you know, an up-and-comer, which seems the numbers go up every year, is internet use and games. And, you know, that may be a new field of psychiatry, but, you know, that's something else we have to pay attention to. What are the key health issues that we need to pay attention to on campus? I think #1 is rapid access to care. And this is another example of how we can all learn from each other. When students are in distress, and, you know, you heard very eloquently from Paul, you know, what it's like for parents in distress. When students are in distress, you have a window of opportunity. And if a student calls up the counseling service and says, yes, we can see you in a month, you know, we'll give you an appointment 4 weeks from Tuesday, the likelihood the student's going to show up for that appointment is pretty small. So you need to develop systems where people can have very rapid access to care to figure out how crucial this is. So if someone is feeling acutely suicidal, you know, they get seen immediately. If they're breaking up with their 15th or 20th boyfriend or girlfriend and they want to talk about relationship issues, you know, that might wait a couple of days. But you need to know that up front, and you need to have students get access up front. There's a triage system, and this is something that makes sense for larger institutions. For smaller schools, I don't think it would work as well. The University of Massachusetts developed a triage system that now many of us are using. And it's essentially when a student calls up, they're given a phone or face-to-face intake, a very brief intake with a senior clinician, and a clinician makes a quick assessment. You know, what's going on? What are the issues that you're concerned about? If the student has an eating disorder, we refer them to someone who's got expertise with an eating disorder. If a student is on 4 medications and having side effects, we refer them to a prescriber. If a student wouldn't go on medication in a million years, we don't tie up an hour of a psychiatrist's time talking to the student about medication at that point. So we try to match students up, and also the level of urgency of appointments. And it's helpful for the counseling staff because you know, they can kind of, you know, balance the level of urgency, and it also gets students seen very quickly, which I think is crucial. I also think coordination of care across the campus, and I cringe whenever I hear counseling staff, when a dean or a parent or someone calls up and the first word out of the counseling staff's mouth is, sorry, I can't talk to you, I don't have permission. That's the wrong attitude. You know, the attitude needs to be, I would love to talk to you, here are the parameters around confidentiality. You know, I'm happy to listen to you, we can figure out ways to have dialogue, you know, ask your son or daughter for permission, and we can talk about these issues. Don't tell me the name of your son or daughter, and I can give you general information about how to approach these kinds of problems. So we really want to work together with all the constituencies. And, you know, I think parents are also a very important one that are underutilized. And I'll make a recommendation. The National Mental Health Screening Organization, mentalhealthscreening.org, all one word, they have their website has online anonymous screenings that people can have access to. And they also have a section for parents, some guidelines for parents to how to help make referrals and get your kids into care. And that's available on the web. There are a lot of other good web resources. I'll refer to the JED Foundation and others in a couple of minutes. Okay, 3 more minutes. Medical leave and legal issues. I think that sometimes students need to take some time off. I think we need to help make that process an easy one and also carefully reassess students when they come back into campus so that they're ready to be back in an academic environment. Student participation, you heard from my example, is crucial. There are many different ways students can be involved on campus. You've heard about student advisory groups earlier. We have a mental health advocacy groups. I think some schools are having creative programs, Freshman 101, teaching wellness activities to help students adapt to college. Some of the clinical challenges, having adequate prescribing capacity, which most schools don't have, having adequate prescription coverage for students when they need to be on medications, which most students don't have, and identifying high-risk students and making sure that you have resources available on campus or off campus with coordination to meet these needs. Community challenges, the biggest challenge for all schools is how much care for whom? The students who are in the most distress and need the greatest amount of resources, do they get the bulk of your resources, or how do you sort that out? Do you do screenings at the point of admission? What kind of insurance expectations? We all want parity, but there are things that still need more work. Web information, I mentioned mental health screening, the JED Foundation, mystudentbody.com, alcohol.edu. There are lots of good web resources. There are also lots of terrible web resources, so you need to do some research and identify the places that seem like they're good sources of health information. Innovative programs, the triage system I mentioned, these credit courses for incoming freshmen, various kinds of suicide prevention programs, web-based screenings. And I will stop with that, and we'll save time for questions. Thank you.
I like that iPod idea. Our next speaker is Dr. Morton Silverman, who's the Senior Advisor to the Suicide Prevention Resource Center in Newton, Massachusetts. Dr. Silverman is also a Clinical Associate Professor of Psychiatry at the University of Chicago, where for 15 years he also served as the Director of the Student Counseling Service and Associate Dean of Students. Dr. Silverman will address us regarding stigma in the graduate professional school environment. Morton. Please join me in welcoming.
Hold your applause for later. It's more meaningful to me afterwards than beforehand. Let me start off by thanking also Dr. Graydon and Sarah and Lynn for a fantastic conference and for inviting me to participate. This is my second year that I've participated in this conference, and my impression is that they just keep on getting better and better, and I hope we'll have another one next year, but we'll talk about that this afternoon. I have a lot to share with you. I asked that copies be made of all the slides so that you should have them. I tend to, in a limited time frame, and especially because this panel is the panel before lunchtime, I have a tendency to speak very quickly. As a matter of fact, last time I was on a panel like this before lunch, I told the folks in the audience that I have a tendency to speak very quickly, and if I was going too quickly, would somebody raise their hand and let me know? Well, sure enough, about 5 or 10 minutes into my presentation, somebody raised their hand in the back of the room, and I said yes, and they said, Dr. Silverman, please speak faster. So we'll see how this one goes. Let me first give you a little context. The Big Ten suicide study was something that I was involved in. The University of Michigan was part of this study. What I want you to take a quick look at is the age ranges of 25 and above. And what you see here is that about 40% of all the suicides that occurred in the Big Ten suicide study were graduate students, or at least older students over the age of 25. If you look at their actual class, you'll see that a third, 32%, of all the students who died by suicide in this study were graduate students. And in my opinion, the graduate students are a group that are not often discussed, not often approached, because they're not undergraduates and they don't always grab our attention. But if you look at what happens to graduate students in terms of their rates of suicide, what you see if you look down at the 25 to 29-year-old and above, you see that females in those age ranges, and most of them were graduate students, have higher suicide rates than in the national population, matched for age and gender. And this is of great concern, that far and away females, particularly graduate school females, have a higher suicide rate than females in the general population. And if you look at the 35 to 39-year-old range, both males and females have a higher suicide rate than matched samples in the general population. In response to these kinds of findings, the Committee on the College Student, which is part of the Group for the Advancement of Psychiatry, a professional organization, wrote this book, and it's published by the Hayworth Press, 1999, and we, as a committee, tried to figure out how to be of help to graduate students. And what we discovered was that there's a tremendous amount of stigma for those people who go to graduate school, particularly women who go to graduate school, and particularly women who go to graduate school in the professional areas, law, business, and medicine. And what we tried to do was to come up with some policies and approaches to assist administrations and universities to assist students to make it through the graduate education. Graduate students are a difficult group to characterize, as you can imagine. They're all over the place. They're different age ranges, and they are difficult to reach. They're not in the dorms. They are not on intercollegiate sports teams. They're divided up amongst many different schools, which have their own deans of students, which have their own cultures, and so it's a very disparate group. But as you can see, they're definitely at risk. How many graduate students? How many graduate students are out there? Well, there are 14 million students enrolled in colleges and universities, 8 million in the age range of undergraduates, so about 6 million or more students fall into the graduate student range. One of my hats that I wear is as a senior advisor to the Suicide Prevention Resource Center. We just put this out. It's a 33-page document promoting mental health and preventing suicide in college and university settings. We published this in just last October. It is available free of charge, www.sprc.org/library, and you can access this and download it. And in our opinion, it is probably the best summary right now of approaches to promoting mental health and preventing suicide on university campuses. The SPRC is working with the JED Foundation in implementing some of our recommendations, which look like this, on different campuses as we speak. And there are a number of campuses in the Northeast who we're working with to try to implement some of these approaches to see if it really will make a difference. Not only are these areas ones for suicide prevention, but if you take a different slant on it, these are also areas where stigma exists. And if one can think about where on a college campus one might approach not only preventing mental health problems, but on the same hand, looking at what is the stigma that's preventing these different sectors of a campus to approach the problem and be of help. What I was asked to do was particularly to focus on medical students. The American Foundation for Suicide Prevention recognized that physicians have a problem. Turns out that physicians have a higher suicide rate than the general population, matched for gender and race. And so in October of '02, a work group got together to look at physician suicides and what to do about it. And in fact, published a paper which appeared in JAMA in June of '03, talking about how to confront depression and suicide in physicians, and listed a number of recommendations and policy approaches to deal with this. In the process of looking at physician suicide, we also reviewed the literature on medical student suicides and mental illness. And it turns out that there's been a number of papers and studies that have looked at medical student suicides. And what they found is that the area or the year in which students tend to have the most difficulty, at least for medical students, is during their second year. And I can talk later about why the second year has turned out to be the most difficult one. But both in this study and an earlier study that was done in 1981, it turned out that the majority of suicidal problems occurred in the second and third year of medical school. Not only have medical students been studied in terms of suicide, but they've also been studied in terms of depression. And as you would expect, medical students are not immune to psychiatric problems. And again, the findings from this study and others suggest that about 22% of medical students have a diagnosable mood disorder, 32% have a diagnosable adjustment disorder, and about 13% have a diagnosable anxiety disorder. Another study that is more recent, that just came out in September of 2002, looked at similar, I'm behind myself, here we go, looked at depression in medical students and their use of mental health services and what were the barriers to their use. That's why I'm here today, to talk about these, and I'll get to the reasons why medical students don't use mental health services in a moment. But I wanted to first give you some indication of some of the stressors that medical students face. Adjusting to the identity of being a professional and being in the healing profession, the amount of knowledge that has to be acquired over a very short period of time. At the end of the second year, they have to deal with board examinations, preparing for residencies. It just doesn't stop with medical school in terms of being competitive and continuing one's training. And these days, accepting the reality of a very changing field that is not going to be the same 10 years from now that it is at the point that they're being trained. Furthermore, they're looking ahead, and what they're looking ahead at is that that residency training also has its own set of stressors, and here are just some of them that affect residents. And so this group is looking ahead to their next phase and recognizing that problems don't go away, and in fact, some problems actually become more complicated. Getting back to the previous study, here are the reasons why medical students say they do not seek help. What a surprise. What's interesting is that physicians give basically the same reasons. They say time demands prevent physicians from seeking mental health care. They deny the symptoms of psychiatric illness, and particularly they deny that depression is a leading cause of disability. And they deny the fact that having a depressive illness interferes with good patient care. Furthermore, there's discrimination for physicians in medical licensing and hospital privileges, in professional advancement, and even in the area of medical malpractice coverage, which these days, as you all know, has gotten to be a very expensive issue. Oh, okay, I'm running out of time. I'm just getting going. So stigma exists throughout the entire professional field, starting at the medical school level, at the residency training level, and right through the practice of medicine. So what do we need? We need to educate medical students and residents about depression and suicidality. We need to encourage medical students to seek help and to reduce some of these barriers to seeking help. We need to help medical students with social support and networks and caring about their mental health as well as their physical health. And basically what I'm advocating for is a cultural shift. And if the cultural shift doesn't start at the professional school level, then it surely is not going to carry over into the professional world itself. And I've sort of focused on medical students, but it's really no different for law students, business students, or other professional graduate school programs, that they too have many of these problems, and they too have barriers to seeking help. Where I came from, a lot of the law students would tell me that they wouldn't come for mental health care because they were all expecting to someday be Supreme Court justices, and they knew that there would be background checks along the way, and they didn't want it on their record that they had ever sought mental health care. I think that's a little far-fetched as a reason for not seeking help, but that's the kind of barriers that we have to deal with in terms of professional organizations, professional training programs. Here comes the pitch. The pitch is that I work for the SPRC. This is what we do. This is who supports us. I, too, am from the government. But rather than being here to help you, what I'm asking is for you to help us. And the us is the Suicide Prevention Resource Center. We are mandated to take public health approaches to prevention, and we support the National Strategy for Suicide Prevention, which has as one of its 11 major goals, Goal 3, which talks about reducing stigma in the area of depression and suicide for consumers of mental health services. So one of the major goals of this national strategy is reducing stigma, not only at the level of the consumer, but also at the level of the care providers who may not be trained, may not be sensitive enough, may not be aware enough to deal with or recognize that depression and suicidal issues exist in their clientele. I will end there. I will be happy to take any and all questions during the question and answer period. Thank you. All right, this should, go ahead.
Thanks. I'm sorry I'm such a slave driver here. And these are all important topics, and I think as Dr. Kadison said, they all can each be an hour and a half presentations on their own. Unfortunately, the time constraints make us push ahead, and our last speaker is Barbara Blacklock, who's a disability specialist at the University of Minnesota. She's worked in the area of disability services for over 25 years at the University of Minnesota. I think this is a very important area, the intersection between disability and clinical services and the administration on college campuses. So, Barbara, welcome. So I hit F5.
I can help you. No, I'll get it. Just close his.
Thank you.
Sure. Let's wait till it comes up and I'll hit it.
The answer is there aren't enough of us.
Thanks. Well, I'm just delighted to be a part of this conference, and I too want to thank the coordinators for inviting me. And I'm just delighted to have the opportunity to share this information with you, and also feel like I have the challenge of trying to go through a lot of information quickly, so I certainly will invite questions at the end. What I would like to do today is to share with you, as was mentioned, I'm from the Disability Services Office, and 6 years ago, our office ran our numbers for the year, and we typically are serving about 1,200 students a year. I'm from the second largest university in the country. But when we ran our numbers, we were surprised, and we ran them twice. And what we found is that the largest group of students that we were serving were students with documented psychiatric disabilities. Prior to that, the largest group had been students with learning disabilities, And this trend has continued in our office, and this has continued to be the largest group of students that we've been serving. As a result, we also were aware that we have done a lot on our campus, as many of you have done on your campus, to make sure that the campus environment is accessible for students with physical disabilities or sensory impairments. But here we had the realization that the largest group of students that we were serving, we weren't real clear on what the barriers were that they were facing. So what we did is we wrote a FIPSI grant, and we're fortunate to be awarded that grant. And what I would like to direct you to is your binder today, because I did include the executive summary from the grant, and I'm going to be going through just very basic pieces of that. And to give you a context for that, I'd invite you to read the executive summary. In addition, in your binder, you'll find a copy of the slides. Our purpose in writing the grant was to gather comprehensive data on the needs of college students with psychiatric disabilities, and also to identify the barriers that they're facing, and thirdly, to make sure that we had some information on the potential strategies that could help remove those barriers. So what I would like to do is share with you in a nutshell. I'm not going to give you a lot of information on how we collected the data or details of these barriers, and that's something that you'll find in the executive summary. But I would like to share with you the 5 primary barriers that we found, and this was from visiting 13 campuses across the United States. We had just under 300 people that participated in focus groups. On each campus, we conducted 3 focus groups. And what I'm sharing with you is the outcome of those interviews. No surprise, the #1 barrier on all the campuses, this included Ivy League schools, large research institutions, state schools, community colleges, on every single campus, the #1 barrier reported was stigma and stereotypes. A subset of that was both stigma external, which we've all talked about at the conference, and also the internalized stigma that students felt, and which was a barrier for them to seek treatment. The second barrier, the complex nature of psychiatric disabilities. What we heard from students is that they were struggling with being a student on a campus, and in addition, some had come to campus with a psychiatric diagnosis and were trying to figure out their support network on campus, and some of these students were having new diagnoses. And so they were not only dealing with all the student life issues, they were also learning to live with a chronic health condition that they felt they couldn't talk to anybody about other than if they had access to clinical services. Organizational and institutional barriers, there were many barriers here. And one I would like to highlight is that we thought that we would hear from students that there were certain kinds of teaching strategies that faculty could implement that would create less barriers in their classes. What we learned from students was that the barrier was classes that were taught in the same way over and over without any variety in the class, meaning that it was a class that only had papers or only had projects or only had exams. What the students told us is that it was a barrier to them to have only that one option in a class. Limited student resources and insurance. As I said, we visited 13 campuses. Every single campus said they did not have enough resources. They were all struggling to do more with less, and also the students were struggling to sort out, if I take less than a full-time load, I don't think I can have health insurance, I need to figure out how to do everything, work, go to school full-time, and manage this illness, and something wasn't working. Lastly, the last barrier was limited access to information and services, and all the focus groups reported that all the stakeholders were struggling in having adequate information. This included faculty who felt that they didn't have the information of what to do if they had a student in their class that was disruptive. Actually, in the focus groups, we spoke with just under 100 faculty, and we didn't hear any examples that they had problems in their classes. What they were talking about is that they were worried they would have a problem, and they didn't know where the resources were on their campus. Mental health providers also felt like we had both off-campus and on-campus mental health providers in the group. The off-campus mental health providers felt a real disconnect with the campus. Some of them were relying on their own graduate training to say, well, when I was there, I was able to do this and this, so I'm not sure what to tell my clients. But there was a real disconnect between the off-campus and on-campus mental health providers. Students felt like they did not have enough information. We did the focus groups on our campus. We thought we were doing a great job advertising our services, disability services on our campus. And we were dismayed to find out that we were like all the other campuses. The students were not getting that information, and it was not adequate to just give that information at orientation when the students are getting so much information that it needs to be available and present throughout their academic career, from undergraduate all the way through graduate school. This would have been a really gloomy study if we were only focusing on the barriers. And fortunately, we're also asking questions during the focus groups about strategies that could help remove those barriers. In a concept that might be somewhat unfamiliar to some of you, and there are certainly websites that have more information about the principles of universal instructional design, and there is information in the executive summary about that. But that was for faculty to start using these principles to make their classes accessible and welcoming to all students. And that in itself could be an all-day presentation. Improving clarity, coordination, and communication among key stakeholders. We were identifying the key stakeholders as faculty, staff, students, mental health providers, disability service providers, and administrators. And all of those groups needed to have more clarity on their roles, their limits, and students understanding what their role is in the process to get the services that they needed. Ensure access to resources, training, and strategies for key stakeholders. One of the things that I'm always careful to talk about is with faculty in our faculty focus groups. We clearly heard from them that they did not feel like they needed more training. They told us they needed access to more information, resources, and ways to gather informally to talk about these issues, because they felt very isolated in addressing issues of student mental health on campus. Reducing student isolation. We unfortunately spoke with a lot of students. We met with just under 100 students, and those students told us that they were not talking to anybody about their mental illness. They were dealing with a chronic health condition that they had to deal with in isolation. We heard many examples from students that I was in the hospital. I didn't get flowers. Nobody came to see me. And someone else on my floor, they were in the hospital for mono. We all did a big sign, brought balloons, and they talked about how isolated they were. And one of the outcomes of our project, which we were delighted, an unexpected outcome, is on 4 of these 13 campuses, after conducting the focus groups, students left the groups and demanded to have support groups on their campus, to have opportunities to interface with other students with psychiatric conditions who were also students, groups that weren't just therapy groups, but were truly support groups. When we left those groups, the students who, you can imagine that it was challenging for groups of 12 students who all knew they were invited because they had a documented psychiatric disability. We recruited the students through the disability services offices on these campuses so we could verify that they did have a documented disability. But those students said to us, promise us that this information just won't sit on a bookshelf. What we found is that we were out of money. We all had day jobs that we had kind of tried to balance while we were doing this research. And so what we did is we identified on our campus a small work group that was composed of the stakeholder groups.
the campus, one of the campus psychiatrists from the mental health center, someone from the counseling center, a student who was a consumer, someone from the faculty senate, someone from the health promotions office, someone from disability services. We met monthly for 5 months, and we made a lot of strides. We identified the barrier that we wanted to address first on our campus, which was to improve clarity, coordination, and communication among key stakeholders. A couple of the outcomes from that were we identified in our offices liaison relationships and the people who we needed to call and clarified our roles. We also have put together the text for a website for information to post on our websites. Again, that title about students with mental illness, psychiatric disabilities kind of threw us for a while, and we came up with a header that was assisting students in distress, and it's designed for faculty and staff to get information and how to deal with situations that they were faced with. What we found is that we hit a roadblock. We realized we needed top administrative support for this project. We found that our website, our campus website, was a barrier. We brought in the associate provost to our last meeting, and we did a search of our website on our campus, which is called One Stop. We searched for depression, and all we got was 2 research projects. We didn't get the counseling center, we didn't get the mental health center, we didn't get any of the resources on campus, and recognized this system has to change. So we went to the provost, and we presented him, from the group had generated this information, that if there were no steps taken to form a campus-wide committee and to address this as a public health issue, what would be happening is that staff would be using excessive time in responding to the needs of students with mental health issues, that they were going to be doing it in isolation. This would also lead to more job stress for faculty and staff. There would be a reduction in graduation rates because students would not know that they could stay in school and reduce their course load, or did they have to leave, and then how do they get back in, and if they left with a mess, it was going to take a while to untangle that mess. A personal loss for the students in not getting connected to the appropriate resources, and finally, potential litigation. We also presented what the benefits were to developing a committee, that we felt that we could coordinate a system of delivering services on campus that would be easier for students to access, and we had a lot of ideas of how to do that. A coordinated system of resources that provides support for faculty and staff as they work with students who are presenting information to them that they shared with us. They didn't know how to handle that information. We heard from many faculty, I'm not an expert in mental health, I'm an expert in chemical engineering. How can you expect me to do anything? Also, we shared with the provost that developing and implementing a campus-wide strategies to reduce stigma, that this isn't something we can do in isolation. We have to do it as a campus, as a public health issue. And finally, I'm sure many of you are in the situation that we're in when you have a coordinated effort that there isn't a grant writer in the group, and so coming together to work together on grant opportunities as they present themselves. So the outcome of that was, and I think we did a good sales job with the provost, is he did appoint a committee, and we've begun to meet. And this committee has 13 representatives. There's 2 of us from Disability Services that are staffing it and starting it. We're meeting monthly. We have clear objectives. We have a charge from the provost, and we're also going to be providing him with quarterly reports. And our charge is to raise awareness about issues related to mental illness on our campus, affect policy change, improve conditions on the campus for students with mental health disabilities, and finally, serve as a model for campus collaboration. And with that, I'd like to end with a quote that has really offered me a lot of support as I've gone along the road. Never doubt that a small group of thoughtful and committed citizens can change the world. Indeed, it's the only thing that ever has. Thank you. Okay.
Okay, well, why don't you pass your cards in if you can, and also we can use the microphones to start with questions, so please let us know where you're from, who you are, and if you're going to direct your question to a specific panel member. Why don't you start?
Hello, my name is Tamina Modern. I'm a postdoc at UC Berkeley, and I'm asking all of the members who did form committees on their campuses, if you had it to do over, what would you do differently in forming a campus-wide committee? At UC Berkeley, we have just gotten our chancellor to agree to form a committee, and we'd love to learn from your experiences.
Could you? I didn't hear the question.
The question is, if you formed a committee, how did it work, or what you might change or do differently so that Berkeley can take some of the models that you've used?
I can share on our campus, one of the things that we did that I think has been real effective is that, so it's not really a mistake, I think it's been a helpful thing, is that we contacted the key stakeholders and shared with them that we expected that this to be a very focused work group, and that we expected that there would be homework and we'd be meeting monthly. I was the person that was asked to call people ahead of time before the provost sent out the invitations, and I was delighted to find that when I made those calls to the vice president of campus security, when I asked, is there someone on your staff that you think would be able to participate and provide this kind of time and effort to a committee, and his response, which was very similar to many other directors, was, would it be okay if I participated in this? This is a really important issue on our campus.
Richard?
The comment I would make is that it's the stakeholders and the goals of the committee need to be very clear. I think it needs to involve student input, and depending on your campus, often a breakdown of some graduate student and undergraduate student input, because they're very different needs for two different cultures. And there has to be someone from the top, from the provost or chancellor's office, who can also fund initiatives to make things happen. And there's so many things we want to get done on campus. I think it's also very important to prioritize what the key issues are. And again, it involves the disabilities office, the administrators, counseling and health service people, and students.
Okay, next question.
Hello, my name is Alex Wienock, and I'm the graduate student coordinator here at University of Michigan. And I have a question specifically for Dr. Silverman and his very revealing information about graduate students and how they're having a great deal of trouble in college with emotional disorders. And the question I had was, have you come with this information in mind? Are any universities or higher education institutes looking at the difficulty of graduate school and medical school, and specifically how it's being run with the amount of time there is to finish certain programs, or in medical school where you have people who are purposefully sleep deprived and put in situations where it's things such as sleeping and eating and exercising are chances for that happening are a lot lower than optimally would help someone to deal with a depressive disorder. Is there anyone who's looking into changing the whole culture of that, rather than dealing with what seems in some ways a Band-Aid to fix a situation that sort of creates the problem to begin with?
To my knowledge, right now there is no organization or group that is addressing these kinds of problems. The difficulty is whether one should focus one's efforts on a top-down approach or a bottom-up approach, because from a top-down approach, at least for the professional organizations, one might look at professional organizations, societies, licensing boards, and the like, bar examination type state organizations, and hope to affect some changes, at least to destigmatize seeking mental health care at that level, and allow that to filter down to the level of students. Of course, the other approach is to just focus initially on the students who are in training, and hopefully develop a cadre of students who then become professionals and advocate to change the perspectives of the predominant views of their colleagues once they're practicing or out in the real world. Having said that, to my knowledge, at this point there are no organizations, save for things like the American Foundation for Suicide Prevention and a few other groups that are looking at physician suicides and what to do about it. But for graduate students per se, I'm not aware of any national effort.
Let me make a comment about this also, because I think there are efforts happening on some campuses that I think have been very beneficial. And because the graduate schools are also very different, I think having committees of students in each graduate program identifying specific issues and needs in their programs. For example, our chemistry department, our labs are very stressful environments. The graduate students got together, met with faculty, talking about, needing a place where graduate students could get together and not be isolated in their labs, just to get together, having monthly dinners, buffets that were supported by the department, having other activities to reduce stress. In the medical school, students got together and said, I know a lot of my classmates have eating disorders. We get some basic curriculum on eating disorders, but how about having someone from the counseling staff come and talk to, we'll collect a group of students and have a discussion about eating disorders, how to identify them, what to do about them, things like that. So I think a lot of grassroots efforts. I know University of California, Berkeley, I don't know if the person who was just up is one of the people. They did a research project and did an executive summary. So finding out what's happening at other schools around the country, I think, is another good way to get some creative information.
One thing we've done on our campus, particularly related to medical education, is that in the last 6 years we've developed a really strong relationship with the Academic Health Center. And initially there was some resistance in the medical school to put a disability statement on syllabuses, and through that process of discussing that with them, they concluded that every semester on the back of all medical students' schedules is a disability statement that doesn't just say students with disabilities, it says students with documented disabilities, and in parentheses it says learning, psychiatric, sensory, etc., so that students with mental health issues can recognize that that might be a resource for them, and it's in a separate building, and there isn't that sense of, well, if I go there, then the medical school is going to know. So that's been something that has really increased the numbers of students seeking disability services. That we have provided accommodations for medical school students on reduced schedules. They've deaccelerated. They have extra time on exams, taking tests in private rooms, but ways to help with the barriers that exist in that program. And I don't know if I'd call it a Band-Aid, but it's at least giving those students equal access to the stresses that their colleagues are dealing with, so they're not at a disadvantage.
Let me just say one other thing about professional schools. For the most part, they are time-limited training programs. Medical school, 4 years, law school, 3 years, business school, 2 years, and if a student needs to take time off to attend to their mental health needs, then they have to explain at the next level why it took them longer than the prescribed time frame to complete their degree program. And students, at least the ones I've dealt with over the years, find that to be a huge barrier. The idea of having to then later on tell employers or residency program directors or whoever to explain why it took them longer than their peers to get through a prescribed training program or educational program.
I guess my small response would be why aren't universities then extending the program in general? And that's if that's, and of course that's a systematic change. That's huge. But if and maybe that would require therefore more funding from governments in order to do that, to pay for the additional years. But that gets us into additional subjects. So.
Right. Thanks. Okay.
My question is for Barbara. I'm Jody McConnell, and I'm a school social worker at a junior high and a high school. And I'm wondering what's considered a documented disability. So for my seniors who are leaving high school, wanting to go to college, and if they leave with the special education label of emotional impairment, is that acceptable, or they need further?
That's a great question. And in the Americans with Disabilities Act, there is a definition of what is a psychiatric disability. And it is a diagnosis from the DSM-4 on Access 1 or 2 that significantly limits a major life activity that includes learning, working, breathing, sleeping, eating. So things like emotional behavioral disorder is not a disability, but if that person has major depressive disorder and has that label, yes, that could be adequate. So there is really a disconnect between the services in the K through 12 and in higher ed, and there's different laws that we're responding to. So I would encourage families to contact post-secondary schools and ask for documentation guidelines so that they can be prepared for that.
Okay, thank you.
Okay.
My name is Nancy Griffiths. I'm a counselor at a college on the East Coast, which is a professional school. It's a pharmacy and health sciences school. And first of all, I want to applaud and encourage the efforts you talked about, coordinated efforts that schools can make to educate communities about mental health issues. I'm part of a student affairs department, and what's been incredibly effective in terms of depression awareness, eating disorder awareness, is having the whole department sponsor week-long events. There's been a lot of student participation. Our numbers have gone up, and as a consequence, we're seeing a lot more students in the counseling center that come through from those screenings. So it does work. The iPod mentality is a good one. I have two questions, and anyone can address them. One is, on our campus, we have a very high percentage of Asian and Asian American students, about 40%. There's a huge stigma around help-seeking behaviors among those populations, and we're really struggling with how to reach out to them. I'm wondering if any of you in the work that you've done have suggestions or resources or models we can look at in order to better access those students, because what we find is that those students are particularly the ones who come to us when they hit a crisis point.
Yeah, and just to say, stay tuned for this afternoon because the panels are going to be addressing those issues. Yes.
Let me take a crack at question one. I think it is a very underserved and challenging population to reach. We've done a work group on looking at international students in general and how to help them, and some of the real difficult issues. If they take time off, many of them then have to leave the country, and figuring out how to get around those laws by having some sort of temporary leave or ways to get around that. One of the things that I think has made a difference in some of our schools, and we have some of our graduate schools have almost 50% international students, and with the Asian students, there are very big differences in the different Asian cultures. So we also have to be careful about lumping them together. But I think giving students an orientation, a special orientation for international students, because let's face it, when students arrive at a university, they're overwhelmed with information. And the first thing on your mind is not, I'm probably going to be depressed in 3 months. What are the resources? So, providing some separate information just about accessing health care, that in the United States, in many cultures, you're at death's door, and that's when you access health care. Otherwise, you talk to your families and friends or try some herbs. Just learning how to access the healthcare system. If there's a primary care system, most students find that if they have a relationship, just an introductory meeting with a primary care doctor, that person with less stigma can direct them to the appropriate resources. So just telling people that, Healthcare is free if it is, which it is for us, for students on campus, and here's how you access it, and here are some of the signs and symptoms that may come up down the road. If you have those, you should at least, get in the door of your primary care doctor, and then, they can direct you.
In the interest of time, I think we're going to have to end. I'll invite all the people who have questions to come up and ask our panel members. Lunch is on your own, and we'll be back here at 1 p.m. Please join me in thanking our distinguished panel. And thank you for all your great questions and your attention. See you at 1.